Good evening to all of you. At the outset, I would like to thank Parini for giving me this opportunity to be with you all this evening. So I'll be just giving a 15-minute talk on basic examination of pulse. Going into the history of pulse, Hippocrates in 4th century thought that the arteries were air ducts. He thought that air is passing inside the arteries. Then Galen confirmed that arteries contain blood and not air. Herophilus recognized that arterial pulse and cardiac pulses were synchronous. And then in the Yellow Emperor's Book of Medicine was the first to demonstrate the use of pulse as examination, physical examination of a patient. In fact, at that time, that was the only thing we could do physically. If you want to examine a patient, you can only look into the pulse. And in that book, they say that they used to look at the pulses for hours together. And the only thing they could see was the rate and rise of the pulse amplitude and the irregularity, whether it is regular or irregular. So that is how the examination of pulse started. Now, pulse, what we think is that it is the blood flowing from the heart and causing the distension of the arteries that we feel as pulse. No, it is not blood. Pulse is the palpability or peripheral arteries, a pulse wave, which is transmitted wave from the root of the aorta along the vessel wall, traveling 10 times faster than blood. So blood, if you see, travels at 0.5 meters per second, but whereas pulse travels at the speed of 5 meters per second. So before blood could reach here, the pulse wave reaches, and this pulse wave is a pressure wave that travels about 5 meters per second and is propagated by the incompressible blood both forwards and laterally. The lateral movement distends the arterial wall, and that is what we feel as pulse. Now, if you look into the components of a pulse wave, just like you record ECG, pulse also can be recorded by polygraphy. And if you look at the components of a pulse, it contains of percussion wave, which is the impulse generated by the LV ejection. This is the percussion wave. Then the tidal wave. Tidal wave is nothing but the reflected wave from the upper part of the body. And your dichrotic wave is a percussion reflected from the lower part of the body. So all these are reflected waves. And then you have an anacrotic notch in the central pulse, which disappears in the peripheral pulse. And then you have an incisura, which corresponds to the isoarrhythmic relaxation phase, which is prior to the aortic valve closure. Now, what are the pulses that we can feel and examine in the body? There are 12 pulses, of which 3 are in the head and neck. You can feel the superficial temporal, especially in temporal arteritis, we examine this pulse. Carotids can be felt for doing a carotid sinus massage, you use the carotid pulse, and subclavians also can be felt. If you come to the upper limb, again, there are 4 pulses. You can feel the axillary, you can feel the brachial, and radial and ulnar are the commonest pulses which we examine routinely. In the abdomen, you can palpate the abdomen aorta also, but that for that patient should be thin built. An obese individual definitely cannot palpate the aorta. In lower limb, there are again 4 pulses that we can feel: the femoral, the popliteal, posterior tibial, and dorsalis pedis. Now, there is a way to examine the different pulses. I mean, as I'm constrained with only 15 minutes to give a talk, I cannot go on detail about how to position, but I think the picture will tell you. This is how you see the radial pulse. The hand of the patient should be supported by your left hand, and then with the right hand, 3 fingers, you palpate the radial pulse. The femoral artery also, the patient should be lying down, his legs should be straight, and then you can palpate the femoral artery. For palpating the popliteal artery, you make the patient prone, then lift the leg and support it with one hand, and then with the other hand, you palpate the popliteal artery. Posterior tibial, the foot should not be hanging or dangling. It should be supported like this. Once the foot is kept there, you can feel the posterior tibial behind your medial malleolus, and then the dorsal pedis can be felt at this position. In a pulse examination, you have to observe the pulse, because there are many clinical signs where without touching the pulse, you can make out the signs. And then you have to palpate the pulse, and sometimes you need to auscultate a pulse also. Now, on observation, the pulses that can be well made out is the Corrigan's pulse. So this is nothing but the visible carotid pulse in aortic regurgitation. In severe AR, you can see Corrigan's pulse. Then the dancing brachialis. So this is the brachial artery. You can see the artery very well. This you can see in aortic regurgitation, atherosclerosis, and arteriosclerosis. Sometimes you can also see the dorsalis pedis pulsating. So these are the three pulses which by observation you can make out and tell probably why it is. So this is the Corrigan's pulse. You can see the dancing carotids. Now coming to palpation. In palpation, the things that you should see in a pulse are, one is you should count the rate, how many times it beats per minute. Then whether the rhythm, whether it is regular, whether it is irregular, whether it is regularly irregular or irregularly irregular. Then you look for the volume, whether the volume inside the pulse, that is amount of blood in the pulse, is normal volume, high volume or low volume. Then you have to look for the character of the pulse, which I'll come to in my subsequent slides. Then whether you should look for whether it is palpable in all the peripheral accessible vessels. Sometimes in peripheral vascular disease, you might not be able to feel the peripheral vessels if they are involved in the disease. Then you should look for thickening of the vessels. In atherosclerosis and arteriosclerosis, the vessel walls thicken and you can palpate the vessel also. Then you should look for radiofemoral delay, pulse deficit, grading of pulses, and peripheral signs of AR. So let us look into all of this. And auscultation, sometimes over the subclavian artery, you can hear the innocent systolic murmur, which is a murmur without any cardiac pathology. Then in the interscapular region, you can hear the coarctation of aorta murmur. In the abdominal and bifurcation, you can see, you can hear a bruit if it is iliofemoral obstruction or a Leriche syndrome. And in the flanks, sometimes you can hear renal artery stenosis, a murmur. Then once you have felt the pulse, you should grade the pulse. Pulse grading is from 0 to 4 plus. If there is no pulse, you grade it as 0. If it is present but diminished, you call it 1 plus. If it is average normal pulse, then you call it as 2 plus. If it is moderately increased pulse, then it is 3 plus. And markedly increased pulse, you call it as 4 plus. So these are the various abnormal pulses, and let us look into each of them. So first is pulsus parvus. Pulsus parvus is nothing but slow rising pulse. Pulsus tardus is low amplitude pulse. Your anacrotic pulse is nothing but the combination of pulsus parvus and tardus. Then hypokinetic pulse, the amplitude of the pulse is low. In hyperkinetic pulse, the amplitude of the pulse is high. In brisk or jerky pulse, which you see in HOCM, only the uplift or ascending limb is rapid. In water hammer pulse, the amplitude will be, the pulse pressure will be normal. In water hammer pulse and collapsing pulse, the upstroke and the downstroke will be high. In water hammer, the volume can be normal. In collapsing pulse, the pulse pressure will be high. Corrigan's pulse we have already seen. Anacrotic, I said it is pulsus parvus et tardus, combination of low volume and slow rising pulse. In Bispherian's pulse, you have a double peak pulse. Now, double peak pulse you can get in Bispherian's pulse, you can get in anacrotic pulse, and you can get in dicrotic pulse. All three have double peaking. How you differentiate is in anacrotic pulse, the two pulse waves will be in systole, and one will be in the upstroke and one will be at the peak. In Bispherian's pulse, both will be at the peak. In dicrotic pulse, one will be in systole and one will be in diastole. So that is how you differentiate these three double beating pulses. Then pulsus paradoxus, pulsus alternans, and pulsus bigemini, I'll come to in the subsequent slides. Now, what is pulsus alternans? Pulsus alternans is a pulse pattern in which the beat occurs at regular intervals, but in which there is a regular attenuation of the systolic height of the pressure pulse. That is, one pulse is tall, one pulse is small. The pulsus alternans is a peripheral manifestation of LV failure. In pulsus alternans, there is alteration in the height of the pressure pulse, alteration in the rate of rise, and it is the latter that is appreciated during palpation. So basically what happens is, the basic pathophysiology is, because there is LV dysfunction, the muscles are fatigued or tired. All muscles do not act together. When more muscles are contracting, you get a bigger pulse. And then when less muscles are contracting, you get a smaller pulse. That smaller pulse after some time is again able to contract and you get a bigger pulse. So some muscles do not act. That is how you get this pulses alternance. It is better felt in the distal vessels than the proximal. Reason being the rate and rise and peak pressure developed or accentuated during peripheral transmission of the arterial pulse pressure. And light pressure is applied to palpate the pulses alternate. So here you can see one beat is tall, one beat is short, again tall, short. This is known as pulses alternance. Now coming to pulses paradoxes. Pulses paradoxes is an exaggerated fall in systolic blood pressure with inspiration, usually more than 10. Now, why we call it the paradoxes? Because it is something which happens normally. During inspiration, the BP fall is only around 4 to 6 millimeter, but this is exaggerated. But still, we call it pulses paradoxes because at times during inspiration, the pulses are not felt. That is why the name pulses paradoxes. So paradox about the pulse is the absence of pulse during inspiration, but presence of heart sounds, and was coined by Adolf Kussmaul in 1873. Misnomer about the term paradoxes is that normally there is a fall of 4 to 6, but in pulses paradoxes, it is exaggerated, more than 10 millimeters. So why does this pulses paradox happen? Basically, what happens is during expiration, you can see the volume in both the ventricles are equal and the septum is in between. But what happens in patients who have conditions that produce pulses paradoxes, there is increase in the right heart flow. So increased return to the RA and RV causes dilatation of the right atrium and ventricle. This dilated RA and ventricle pushes the interventricular septum towards the left, and this results in narrowing of the LA and LV and decreased cardiac output. That is why the blood pressure falls by more than 10 millimeter during inspiration. During expiration, that fall is not seen. So this is pulses paradoxes. So how do you measure pulses paradoxes? To detect pulses paradoxes, inflate the cuff rapidly above the systolic pressure and then slowly deflate it. The difference of the systolic pressure at which sounds are first heard only during expiration and later during both expiration and inspiration, and the difference at what pressure or what level of blood pressure you hear only during expiration and then during inspiration expiration is the magnitude of the pulses paradoxes. So this is how pulses paradoxes is recorded. Now, if you see the initially you can hear the correct cough sounds only during expiration, whereas during inspiration you do not hear it. So that is at 140 millimeters of mercury. Then when you further bring down the deflate the cuff at 120, you can hear the correct cough sounds during both expiration and inspiration. So this 140 minus 20 millimeter is the pulses paradoxes. Where do you get it? Physiologically, in obesity and pregnancy also you can get pulses paradoxes. Respiratory causes, bronchial asthma, emphysema, COPD, and large bilateral pleural effusion. And cardiovascular causes, you can get it in hypovolemic shock, constrictive pericarditis, cardiac tamponade, pulmonary embolism, RV infarct, cardiomyopathy, SVC obstruction, and post-thoracotomy. Now coming to radiofemoral delay. If you look at the time taken by the aortic pulse wave to reach from the aorta to the carotid, it takes only 30 milliseconds. From the aorta to reach the brachial, it takes 60 milliseconds. From the aorta to reach the radial, it takes 8 milliseconds. And to reach the femoral, it takes 75 milliseconds. So if you look at the, difference, the time to reach radial and femoral is almost the same. This 5 milliseconds you cannot make out clinically. So normally there is no radiofemoral delay. Then how do you look for radiofemoral delay? You should keep the hand radial pulse and the femoral pulse both together. So bring down the patient's arm, keep it adjacent to the femoral artery, and then palpate simultaneously both the radial artery and the femoral artery. If the pulsation you feel in the femoral is little delayed from the radial pulsation, we call it as radiofemoral delay. This you can see in coarctation of the aorta, atherosclerosis of the aorta, thrombosis or embolism of the aorta, and aorta arteritis. Basically, here it is not that the pulse is arriving late in the femoral, it is only peaking later. And because it is peaking later, we have the illusion of as if it is occurring late. So that is your radiofemoral delay. This is a very important sign. And I mean, sometimes you can miss a coarctation. If you had done looked for radiofemoral delay, you will not miss the coarctation. Then lastly, coming to the peripheral signs of AR. So these are nothing but prominent pulsations of the different arteries producing signs. So there are 20 peripheral signs of aortic regurgitation, of which 10 are seen in head and neck. So if you see the head bobbing during each systole, it is known as Demusset sign. If you see alternate flushing and blanching of the face, that is known as lighthouse sign. If you see alteration in the pupillary size, then that is known as Landolfi's sign. If you see capillary pulsation over the lips, it is Quincke's sign. If you open the mouth and see the uvula pulsating, it is Muller's sign. If you are able to palpate a thrill over the carotid during upstroke, it is carotid shudder. If you are able to see the carotid dancing, that is known as Corrigan's pulse. If you are able to see pulsations of the retinal vessels, that is Julien's sign. And then the tongue depressor moving up and down when you depress the tongue with the tongue depressor, that is known as Minervini's sign. And sometimes sternoclavicular joint, when you palpate, you will be able to see pulsations. That sternoclavicular joint pulsation is known as Logis sign. Then you can see 7 signs in the limbs. If you see a double peaked pulse, it is the Bispherian's pulse. You can see the locomotor brachii, which I showed, which is known as dancing brachialis. And then the lower limb BP will be more than 20 millimeter than upper limb. Normally, it will be less than 5 to 10 difference because of peripheral augmentation. You can have the peripheral pulses a little higher. But if it is more than 20, it is known as Hill sign, indicates aortic regurgitation. And higher the Hill sign, it indicates that the AR is severe. Then if you hear systolic sounds over the femoral artery when you auscultate, it is pistol shot femoralis. If you hear systolic and diastolic sounds over the femoral artery while auscultating, it is Straub sign. And then with the stethoscope bell, on distal occlusion, you will hear a diastolic murmur. If you lift and again do occlusion proximally, you will hear a systolic murmur. That is your Durocher's murmur. And you can hear pistol shot over the radial artery also, which is Palfrey's sign. And then lastly, in the abdomen also, you have 3 signs. If you have liver pulsation, it is Rosenbach sign. If you can see splenic pulsation, it is Gerard's sign. And in women, if you see pulsations in the cervix, it is known as Denison's sign. So in aortic regurgitation, there are a lot of signs over the head and neck and limbs, which one, if you observe, you can easily diagnose aortic regurgitation and wide pulse pressure. Thank you.
That was a wonderful talk, Dr. Ezhilan. I'm sorry I got disconnected in between. And I request very, very nice talk. I listened to your entire talk. And